Hi guys, welcome back. Today we're going to do the end of rotation lecture for the HEENT segment, head, eyes, ears, nose, and throat. This pharmacology section is going to focus really on infections that can be present in the HEENT area. We're going to focus on some of the most common infections that like a PCP would see, and that would be acute pharyngitis, which is most commonly strep. We'll look at sinusitis, and then we'll look at otitis media. We'll talk mainly about these infections in adults, but then we will also mention, common treatments or first-line treatments in children. Okay, so we'll start with acute pharyngitis. Pharyn, like the pharynx or throat, itis is inflammation. So pharyngitis is just an infection in the throat. Acute pharyngitis is a very common cause of ambulatory visits. It's one of the more common infections that patients will present with. Signs and symptoms of acute pharyngitis include sore throat. Patients will typically have pharyngeal edema. So when you look into the throat, you'll frequently see that there's red, swollen throat. Patients will have, commonly the tonsils will be kind of angry, looking red and inflamed. It's common to see petechiae inside the throat in the oral and pharyngeal mucosa, like little red dots, petechiae. And then also, if it's strep pharyngitis, we'll commonly see tonsillar exudates, like white kind of material accumulating on the tonsils, which you see in the picture on the top. We'll talk about the pictures in just a moment. Other signs of acute pharyngitis include fever, headache, and just general malaise, which those three are kind of non-specific symptoms of infection in general. Most commonly, acute pharyngitis is viral. Viral pharyngitis is typically self-limiting, so patients don't feel well, but just encourage them to stay hydrated. They can use lozenges to help soothe the throat. Whatever feels good, tea with honey or soup, nice soft foods. They could take Tylenol for the fever, but in general, the virus just kind of has to run its course. Bacterial pharyngitis is another case. Bacterial pharyngitis is usually caused by group A strep. And this is problematic. Patients who have group A strep do need to be treated with antibiotics. So when a patient comes in with acute pharyngitis, you can commonly see that it's group A strep when you examine the throat. Group A strep, again, is typically associated with these patchy tonsillar exudates. So for example, in this top right picture, all of this like white that you see on the tonsils, you can actually see it in this first picture as well. There's white here and here. That is a sign of group A strep infection. Patients will frequently also have prominent and tender anterior cervical lymph nodes. So you can, palpate the anterior cervical lymph nodes, and again, that'll be tender. Again, we frequently also see palatal petechiae. That's like up here. This patient doesn't really have it, but up here in this soft palate area, up here and here, you'll see like little red patches and red dots. And then again, just in general, the throat looks red and angry, and commonly the tonsils are swollen as well. Patients who have group A strep, so like when a patient comes in with pharyngitis, you can very quickly do a strep test. You can see if they have group A strep or not. Patients who are positive, if they have a positive rapid strep test, then antibiotic use is indicated, period. If it's negative and you think it's viral, you just let it run its course. However, group A strep is associated with some complications that can be rather serious. So some common complications include otitis media, especially in young kids. The bacteria can go through the auditory tube and enter into the middle ear, causing an ear infection or otitis media. Peritonsillar abscesses are also possible. You can see how angry the tonsils are. So this can kind of progress until there's an actual abscess. Also, and this is more serious, is that rheumatic fever is a possible complication of untreated or undertreated group A strep. In terms of rheumatic fever, so when you look at patients who have rheumatic fever, inadequate antibiotic treatment of strep pharyngitis or no treatment of strep pharyngitis increase the risk of developing acute rheumatic fever greatly. So again, when you look at the patients who actually have rheumatic fever, about 1/3 of them had strep pharyngitis that wasn't treated or wasn't treated appropriately. So that's a pretty big number. Patients with rheumatic fever, 1/3 of them, it was associated with an untreated group A strep infection. So if patients have strep throat, you treat the strep throat with antibiotics. So here in the chart, you can see the recommended and common treatments for strep pharyngitis, or acute pharyngitis caused by group A strep. These charts on this page and then on the next page, these are from the guidelines, the most recent guidelines for the treatment of group A streptococcus caused pharyngitis. So the drug of choice for strep throat is penicillin or amoxicillin. So the group of antibiotics that we typically recommend are the penicillins. Either penicillin or amoxicillin are allowed, are okay. Amoxicillin is generally preferred because it's easier dosing. Penicillin has to be taken more frequently. Also, if you're talking about treating children, amoxicillin tastes way better when you're looking at like liquid, the suspensions. Amoxicillin is much better tasting, so kids are more likely to take it without spitting it out. But penicillin or amoxicillin is recommended. Here you can see the dosing regimens. Here. Notice that they're both for 10 days. So recommended therapy is going to be, either penicillin 3 times a day or amoxicillin for 10 days. If patients have at the bottom here, this is Pen-G. Pen-G is the intramuscular, the injectable penicillin. This is usable. You can do this if it's available. It just tends to be more expensive and it's not available everywhere. And it's a shot. So, some patients don't like getting shots. But penicillin G, the nice thing about it is it's just one dose. Just intramuscularly, one dose, and then they're done. If patients have a penicillin allergy, your choices depend on kind of the severity of the allergy and if it was a true allergy. So if patients, say that they have a penicillin allergy, you can give them a first-generation cephalosporin, like cephalexin. However, remember there is some cross there. Like there are patients who have penicillin allergy who will also be allergic to cephalosporins. So if the allergy was a really mild allergy, or when the patient explains it, it sounds kind of doubtful that it was a true allergy, like an allergy that's mediated by IgE. So if it's really mild or it doesn't really sound like a true allergy, or if they tell you that they've had cephalosporins before and they were fine with them, then cephalexin or another first-generation cephalosporin is recommended. If patients had a severe allergy and a true allergy to penicillins, then you don't want to try the cephalosporin. In that case, a macrolide should be given. Azithromycin is generally the preferred macrolide over clarithromycin. I'll talk about why in a second, but azithromycin is generally preferred. A Z-Pack is fine, Azithromax Z-Pack. That's like the dosing pack where you take 2 tablets on day 1 and then 1 tablet on days 2 through 5. So it's a 5-day dose pack. That is one thing that's nice about the Z-Pack, is that it's only 5 days instead of 10 days. However, the Z-Pack is not first line. One of the reasons is because there's a lot of resistance developing to azithromycin. This is just showing us the possible alternatives if patients have a penicillin allergy. This here is just listing out the cephalosporins. Again, generally we would use a first generation cephalosporin like cephalexin. This is also going to be for 10 days. Cephalosporins, again, are only used if the patient can't take the penicillin or amoxicillin. So if they have a mild allergy or they know that they're not allergic to cephalosporins, you can go ahead and give them the cephalexin. In general, cephalosporins are more broad spectrum compared to the penicillin, so that's not a good thing. When we know exactly what we're treating, then we give targeted therapy. The more broad spectrum, the more likely that we're going to cause some antibiotic resistance, and the more likely that patients will have adverse drug effects like antibiotic-associated diarrhea or some sort of yeast infection. So we try and stick with amoxicillin or penicillin if we can. Here, this is showing us the macrolide. Again, if patients have a true allergy to penicillins, and it's not a super mild allergy, so like if they get hives, if they have any swelling whatsoever, then that would be an instance where, and definitely if it was an anaphylactic reaction, that would be a situation where we would give a macrolide instead. So for strep throat, azithromycin is generally preferred. It's better tolerated than clarithromycin, tends to just have fewer adverse drug effects. So we would give azithromycin. Here you can see the dosing for azithromycin. It is okay to give the Z-Pack where you give, 2 tablets on day 1, which is I think 500 milligrams on day 1, and then you give 1 tablet days 2 through 5. So 250 milligrams on days 2 through 5. There is also a dosing regimen where you give a higher dose for, I believe it's like 3 days instead of 5 days, but the Z-Pack is generally given and well tolerated. Here you can see how we would treat strep throat in pediatric patients. It's still kind of the same thing. Drug of choice is penicillin or amoxicillin. Amoxicillin is better tasting, so we generally go with the amoxicillin. Amoxicillin, when kids, we dose it based on their weight, so 50 milligrams per kilogram per day. And again, we give that for 10 days. With a penicillin allergy, again, the same thing, possible cephalosporin if it's a really mild allergy. If not, we give azithromycin. One thing that is important to keep in mind with this azithromycin is when we look at the dosing for strep throat, we do not give the Z-Pack type dosing. There are situations when we do that for azithromycin. For example, for otitis media, for pneumonia, there's an indication to give 10 milligrams per kilogram on the first day and then 5 milligrams per kilogram for 4 days after. However, when we're treating pharyngitis or sinusitis, that is not the recommended dose. When we're treating pharyngitis or sinusitis in kids, the recommendation is 12 milligrams per kilogram per day times 5 days. I'll let you guys look at this. You can just kind of use this table as a reference. This just has the kind of recommended antibiotic dosing regimens for group A strep pharyngitis in the little kiddos. So you can see the penicillin V, which is the oral penicillin dosing. You can see amoxicillin dosing. And there's just the, the different dosing regimens that you can use. Okay, so we'll go through a case. Our patient is a 5-year-old male who weighs 44 pounds, who just started daycare, which means he's going to be getting sick a lot. Patient presents with a 2-day history of rhinorrhea, right? His nose has been running like crazy. According to his mom, he was perfectly fine until 2 days ago. But now, again, his nose has been running like crazy, and now he doesn't want to eat. He doesn't want to, drink at all. And now, he's had a fever for the last couple days. Upon evaluation, you see his temperature is 101, so he does have a fever. You also note that he does have watery eyes and a kind of red and swollen throat. As part of your evaluation, you do a rapid strep test, and you find that the rapid strep test is positive. So a couple things that stand out. First, I have a pediatric patient. I'm going to note the fact that he weighs 44 pounds because we know that kids have weight-based dosing. My rapid strep test is positive, so I know that I have to treat this. The runny eyes or watery eyes and runny nose, it's like, oh, maybe he has some sort of, virus or some allergies or whatever, but the rapid strep test, he won't eat or drink, so that makes me think, okay, his throat's hurting, and it's all red and swollen, so we checked for strep and he's got it. So whenever it's group A strep pharyngitis, you know that you have to treat it with antibiotics. Now, typically we would give a penicillin. We would give amoxicillin or penicillin, usually amoxicillin in kids, but this patient has a true penicillin allergy. So in that case, we look at our options for the patient. Penicillin V, well, no, penicillin V is a good choice, but not in this patient because he's got an allergy to it. Amoxicillin would be a good choice generally, but again, the patient has an allergy to penicillins. Amoxicillin is a penicillin. Just spilled my water. So no amoxicillin. Azithromycin, 12 milligrams per kilogram per day. This azithromycin is just 5 days. So sorry about that, 10 days, that's 5 days. So azithromycin, 12 milligrams per kilogram per day for 5 days. That is what we would do. Okay, again, drug of choice is normally penicillin or amoxicillin, but the patient's allergic, so we're going to go for the azithromycin. Okay, so let's go ahead and figure out what the actual dose that we're going to give this little kiddo is, and then we'll go ahead and write the prescription for him. So first off, up top here, it shows us the way that the azithromycin actually comes. The azithromycin suspension comes in 100 milligrams per 5 mLs, and it also comes in 200 milligrams per 5 mLs. We have our dose here for strep pharyngitis or sinusitis. The recommended dose for children is azithromycin, 12 milligrams per kilogram per day, and we're going to give him that for 5 days. So we're dosing it in milligrams per kilogram. The weight was given to us in pounds, so we need to convert that pounds to kilograms. Hopefully you guys all know there are 2.2 pounds in every kilogram. So 40 pounds, 40 divided by 2.2, that equals 20. Okay, so the patient weighs 20 kilograms. Here, so patient weighs 20 kilograms, and we have to give the patient 12 milligrams for every kilogram. So our kilograms get crossed out, and we're going to give the patient 20 times 12. 2 times 12 is 24. Add the 0. He needs 240 milligrams per day. So that's how we get our daily dose of 240 milligrams. So our directions, we can't just say take 240 milligrams a day, because the mom is going to look at this bottle of, we're going to give the 200 per 5, and she's going to say, well, how much do I actually give? How do I get 240 milligrams? So we need to figure out how much the patient actually has to take, right? How many mLs the mom actually has to give. So the drug comes in 200 milligrams in every 5 milliliters, right? We want to get to, so we have equals 240 milligrams in X milliliters, because we're trying to find how many milliliters are going to give us 240 milligrams. So if you just cross multiply, right, you 240 times 5, 240 times 5 equals 200 times X mLs. I don't have a calculator in front of me, but 240 times 5, and then you're going to end up dividing that by 200, and that's going to tell you the number of milliliters that we have to give. Okay, so we'll go ahead and write our prescription. We have, the patient's name. We'll put, whatever the patient's name is, whatever their date of birth is, whatever today's date is, and then we're going to give him azithromycin as the drug. The dose or the concentration is 200 milligrams per 5 mLs. Right, 200 milligrams per 5 mLs. How much we're going to dispense, I haven't calculated that yet, so I'm going to come back to the amount of drug we need to give him. The directions on this, I pulled up the calculator, and it's 6 mLs. So he needs to take 6 mLs at a time in order to get 240 mLs. So the patient's going to take 6 mLs by mouth daily for times 5 days. So the patient needs a total of 30 mLs, right? 6 times 5 is 30. So dispense 30 milliliters. I don't know if this actually comes in a 30 ml bottle. If not, the pharmacist will just give the patient more, and they'll add at the end of these directions, they'll put discard remainder, so that the patient knows after that 5 days they need to just throw away the rest of the antibiotic. Right? 0 refills, and then you're going to sign it. And that's it. Okay, so that's it for acute pharyngitis. Now we'll move on to acute rhinosinusitis. And this term rhinosinusitis is technically more accurate than calling it just sinusitis, because really inflammation of the sinuses is almost always occurring concurrent with inflammation of the nasal mucosa. It would be very weird for a patient to have sinusitis without having rhinitis. So rhinosinusitis is kind of describing the whole nasal situation. The nasal mucosa is inflamed, the sinuses are inflamed. This refers to inflammation of the nasal mucosa and paranasal sinuses that lasts less than 4 weeks. This is acute. After 4 weeks, we call this chronic. Signs of acute rhinosinusitis include purulent rhinorrhea, so kind of a mucousy, runny nose. Severe congestion is also a common sign of this. This is because of the inflammation that's occurring. There's actual swelling that's occurring, and then you add that to an increase in mucus production, and the combination of those two things causes a lot of congestion. This inflammation and congestion is frequently accompanied by facial pain and pressure. So patients will say that they feel pressure in the sinuses, and that causes pain. So like if you push here, like in the area of the maxillary sinuses, patients will say that, that hurts, there's pain there. And sometimes that causes a headache as well. Rhinosinusitis is almost always viral. Bacterial rhinosinusitis is only present in about 2% of cases. So almost every patient who presents with rhinosinusitis, it is happening because of a virus. Viral rhinosinusitis is self-limiting. Typically, it lasts between 7 and 10 days, and by 10 days, it will resolve on its own. In that case, we just recommend that patients utilize symptomatic treatment. This is challenging because if a patient feels bad enough that they're presenting to the PCP, they generally want to walk away with an antibiotic because that makes them feel like they're doing something to get better. But an antibiotic is, for 98 out of 100 patients, that antibiotic is the wrong choice. Because it's viral. So the antibiotic's not going to help, and it's just going to increase the likelihood of building up resistance and causing adverse drug effects. So as difficult as it is to deny a patient an antibiotic when they present with rhinosinusitis, unless it's been there already for a couple weeks, then most of the time we just give symptomatic treatment. The next couple slides, we'll talk about what symptomatic treatment is, since that's what you're going to be giving to most of your patients. Bacterial rhinosinusitis, again, is only present in about 2% of cases max. And even if it is bacterial, the general thing that we do first is symptomatic treatment and observation, because even if it's bacterial, it will generally clear on its own. However, there are cases when we will give symptomatic treatment as well as antibiotics, and we'll talk about those situations in a minute. Okay, so acute viral rhinosinusitis. Again, most of the patients who come in are going to have this. Improvement should be expected after 10 days. So that's as you can tell patients. You've been experiencing this for whatever, say 3 days. I would expect that over the next 4 to 7 days, you're going to feel better. In the meantime, we can give you symptomatic treatment depending on what their worst symptoms are and depending on what comorbid conditions they have. If there's no improvement after 10 days, it's likely to be bacterial. At that point, the patient can come back and you can prescribe them an antibiotic, which we'll talk about in a little bit. So symptomatic treatment. There are a lot of different options for the symptomatic treatment of acute viral rhinosinusitis and of rhinosinusitis in general, regardless of what's causing it. The two kind of most recommended things are antipyretics, so acetaminophen, or NSAIDs like ibuprofen or naproxen. Naproxen is generally considered the safer of the two in terms of like cardiovascular effects. The other thing that is highly recommended is the glucocorticoid nasal spray. So glucocorticoid nasal sprays, this includes stuff like Flonase. Flonase is fluticasone. Fluticasone nasal spray. The glucocorticoid nasal sprays are very helpful because they actually decrease the underlying inflammation. Right? Again, there's kind of two things causing the congestion and the pain. That is the increase in mucus production as well as the inflammation. That increase in mucus production kind of exacerbates the inflammation, but remember that mucus is there in order to flush away all of the bad stuff, right? The viral particles, the bacteria, whatever. So you don't necessarily want to get rid of all of the mucus and completely dry up the passages. But decreasing the underlying inflammation can improve a lot of that congestion and facial pain. So glucocorticoid nasal sprays and antipyretics are the things that are generally preferred. Other options are saline nasal sprays, but there are some kind of cautions there as far as bacteria in the water, which I'll talk to you about on the next slide. Anticholinergic nasal sprays, which, again, that dries up the mucus, but it doesn't do anything for the underlying inflammation. And sometimes that can over dry the mucus. And then decongestant nasal sprays. Decongestant nasal sprays include things like oxymetazoline or oxymetazoline. That's what's in Afrin. That causes a faster, it acts as a decongestant faster than the glucocorticoid does. So sometimes patients feel like that's working better, but the glucocorticoid actually causes better decreased in inflammation long term. So glucocorticoids are better than the decongestant nasal sprays. Also, remember that with that Afrin, it can end up causing severe rebound congestion. And that's why we do not use it for longer than 3 days, period. It's just not as effective, and it's got more of a risk of actually causing congestion than the fluticasone. So fluticasone's better. There's also another decongestant nasal spray that's available, and that is phenylephrine. Phenylephrine does act as a decongestant. It does decrease the inflammation by decreasing blood flow. It causes vasoconstriction. So phenylephrine is another option. We also have decongestants available orally. And I'll talk to you about kind of which is better on the next slide. Antihistamines are another option, oral antihistamines, and then oral expectorants like guaifenesin. So here you guys can see kind of all of the different options for symptomatic treatment. I have starred the two things that are preferred. Again, that's an antipyretic like acetaminophen or NSAIDs like naproxen. Those work if the patient's experiencing any type of a fever. They also help at decreasing pain, so facial pain or headache, those can be helpful for. The other thing was the intranasal steroid or glucocorticoid. So that would be like fluticasone or mometasone, which decrease inflammation. It's not instantaneous, but they are very helpful, and they don't have that limit of only 3 days. Other options, things that I want to talk about, I do have starred over here that if you're using a saline nasal spray or any sort of like a saline flush, you have to be careful that the water's sterile. When patients are using some sort of a saline rinse, the water has to be completely sterile water that they're putting up into their sinuses. So we recommend bottled water. Patients should be using bottled water, like in the neti pot, the little like teapot that they fill up and they put like the salt in it and they use it to rinse the sinuses. That can be good at helping to loosen up like really impacted thick mucus without over drying the mucous membranes. But again, you need to tell patients they need to use bottled water. Otherwise, it's possible that they can develop complications like amoebic encephalitis is something that can occur if, dirty water is used. Intranasal anticholinergics like ipratropium nasal spray. This really decreases runny nose a lot, but again, it can overdry. So if the patient has like really, really runny nose, it's just constantly running, this might be helpful to kind of dry that up. But if they have really thick mucus that's kind of congesting, it's probably better to work on like flushing that out with a nasal spray. And then the last thing on this slide are decongestants. First, we have intranasal decongestants and then oral decongestants. Intranasal decongestants, again, include the oxymetazoline and then the intranasal phenylephrine. Phenylephrine we see listed down here under oral. There's also an intranasal form, and actually the intranasal form is the only one that works. I'll talk about oral in a second. But the intranasal phenylephrine can work as a decongestant. The intranasal oxymetazoline, it does provide like a sense of, decongestant effect, and it does it pretty quickly. However, its use in acute rhinosinusitis is not recommended. It's not one of the recommended interventions. And the reason for this is, again, it can cause a rebound congestion, and we have better agents that don't do that. Oral decongestants. As far as oral decongestants go, we have pseudoephedrine and phenylephrine. Phenylephrine orally does not work. Doesn't work. I've been saying this for like 10 years. And actually the FDA just came out saying this. The FDA finally came out and said oral phenylephrine doesn't work. The bioavailability is it's just not high enough. You don't get enough of the drug in you to actually do any good. So if they're going to use phenylephrine, they need to use it intranasally. The problem with oral decongestants as well is that there are cardiovascular effects. They cause vasoconstriction, which decreases inflammation, which decreases congestion. But they also can increase blood pressure and increase, because they cause vasoconstriction everywhere. So those cardiovascular effects are problematic for any patient who has hypertension or other cardiovascular issues. Also, phenylephrine is behind the counter. You don't need a prescription, but you have to buy it from the pharmacy with your license, and it's kind of a pain to get. Here we just see some, other agents, for example, antihistamines. Sorry, this chart kind of got pushed to the side a little bit, but you guys have it on your PowerPoint. This is just showing us the antihistamines. Antihistamines are helpful if the person has a lot of allergies. So if they have, like allergic components to their rhinosinusitis, then antihistamines are helpful for that. Remember, there are first generation and second generation agents. The first generation agents like Benadryl, right, diphenhydramine, cause a ton of sedation. So that's not recommended unless, the patient's taking it at night and they're trying to use it to help them sleep as well. Otherwise, we recommend second generation agents. So that's stuff like loratadine, right, which is Claritin. That's associated with the least drowsiness out of all of the agents, including the other second generations. Okay, so here we're moving on to acute bacterial rhinosinusitis, right? And when we initiate antibiotics. So your patient comes in, right? Initially, you do your exam, they tell you their symptoms, and you're saying, okay, you're diagnosing them with acute bacterial rhinosinusitis. So yes, we're saying we're diagnosing them with bacterial rhinosinusitis. The first thing to do is to evaluate if, first off, how severe the situation is, and if the patient can reliably return for follow-up in about a week. If they cannot reliably return for a follow-up in about a week. So, for example, if your patient is a homeless patient or in some at-risk situation, or say they're a cash pay patient and they cannot afford to come back again for another visit. Or, for whatever reason, you don't think they're reliably going to return to you. Or if there's some other risk factor that makes you concerned, you want to start antibiotics right now, then we'll do symptomatic care and initiate antibiotic therapy now, because we know that this is bacterial. So like if the patient's immunocompromised, okay, kind of the extremes of age. If you've got a really young patient or a really old patient, then we're more concerned. Comorbidities, right? If the patient has, a lot of comorbidities that make them more frail. If the patient has a really severe case, so if they have high fever, consistent facial pain for the last, few days. So if they consistently around the clock, their face is hurting for the last 3-4 days, or if the symptoms have worsened really rapidly. The last couple of days, all of a sudden they've got a high fever, their face is really hurting, they can't breathe at all. Like those are signs that this is a severe infection. And in that case, go ahead and start antibiotics now. But if it's kind of your normal traditional patient, right? You've got a 35-year-old otherwise healthy patient, they're reliable, they always come in for their appointments, they say, yes, I can come back in a week if necessary, then go ahead and hold off on antibiotics. Go ahead and just give them symptomatic care for now, and we'll watch and wait for the next week. If they improve, right, in the next week, they don't have to be completely better. But if they are improving, right, if they say, yeah, it kind of peaked about 3 days ago, but for the last 3 days, every day I feel a little bit better, it's clearing on its own. You don't need to use antibiotics. Just keep taking care of the symptoms as they occur, and great, we saved this use of antibiotics. If there's not an improvement in that week, or if, the patient calls you after, it's kind of a case-by-case thing. So if the patient calls you after 5 days and they're like, it's worsening so bad, I've got a fever of 102, like, okay, at that point you need to just break down and treat it. But if it hasn't improved after a week, then we initiate antibiotic therapy, and we continue symptomatic care. So when it comes to rhinosinusitis, you guys, there's a lot of kind of wait and see what happens. Because remember, it's almost always viral, and that's going to clear on its own within 10 days. After that period, if it hasn't cleared, then it's probably bacterial. But even if it's bacterial, it'll probably clear on its own. And sometimes viral turns into bacterial, but still, in which case it'll probably clear on its own. However, if that bacterial hasn't cleared on its own, or it's really, really serious, then we go ahead and give antibiotics. But this is generally self-limiting. Okay, so here we see our choice of antibiotic, our length of therapy, and our follow-up algorithm. So this is when we've already decided, okay, the patient has acute bacterial rhinosinusitis and we need to give them an antibiotic. Either, it's been a couple weeks and it hasn't cleared, or it is really severe, or our patient is an at-risk patient, and we need to give them antibiotics. So first thing is, do they have a penicillin allergy? If the patient does not have a penicillin allergy, then we say, okay, do they have a risk for pneumococcal or not? If they do, or a risk for poor outcome, which I'll talk to you guys more about in my next, my detailed slides that are coming up. If not, which most patients are not going to be at risk, then go ahead and give them amoxicillin and clavulanic, so Augmentin. um, or just amoxicillin, right? Those are kind of our choices. Amoxicillin, which we can do amoxicillin 500 at least 3 times a day, or 875 twice a day. Or again, we can give the augmentin, the amoxicillin clavulanate. If we do suspect that they're at risk for poor outcome, we go right to the amoxicillin clavulanate. And so the augmentin, the combination, and we do it at a high dose. We do the 2,000 milligram extended release tablets twice a day, right? Most patients are not going to be high risk. So most patients, you'll be able to just give them the just the standard amoxicillin. Whether or not you do the 500 TID or the 875 BID, it's kind of going to depend on your patient. A lot of patients, though, do experience a little bit of stomach upset with the higher dose. So, if your patient says, nope, I'm fine, I can take it, I've got a stomach of steel, doesn't matter. Or it's really important to them that, they not have to take it in the middle of the day, that they just do twice a day, then you could do the 875 and just tell them to take it with meals to decrease stomach upset. If the patient does have a penicillin allergy, we can give doxycycline to, any patient, with a penicillin allergy. Doxycycline is fine. 100 milligrams twice a day or 200 milligrams once a day. Or we can give a cephalosporin. But remember, there is some, cross reactivity between cephalosporins and penicillins. So you do need to evaluate if they can tolerate a cephalosporin. So if they can tolerate a cephalosporin, then we can do a 3rd generation cephalosporin. If they cannot tolerate the cephalosporin, then doxycycline is acceptable. Doxycycline is fine either way. And then this is just our kind of continuation and follow-up. We treat for 5 to 7 days. And then after 5 to 7 days, we evaluate, have they improved or not. If they've improved and everything is great, we just continue antibiotic therapy. We're done, that's it. They go on their way. If we are not seeing any improvement, if they're taking it and we're not seeing any improvement after the first few days of therapy, then we need to first consider, is this the correct diagnosis? If not, then you need to go evaluate your other options and go treat them as indicated. If you confirm, yes, this does make sense, it's just the wrong antibiotic, then you need to change to a different antibiotic. There are a lot of different options as far as antibiotics go. Essentially, it kind of depends on what your first choice was. But if you're using, amoxicillin, you can give them the high dose amoxicillin clavulanate. Or you can give them the doxycycline. Or if you go to one of the other agents that you did not use before, the doxycycline plus clindamycin. All the options are listed here. I'm really more worried about you guys knowing your first step. If you know what your first treatment is, that's generally going to work. And then if that doesn't work, that's when you can go to the guidelines and kind of figure out, okay, what do I do now? But you guys should be comfortable with what your first step is, which again, in this case, is generally going to be amoxicillin, either twice a day or 3 times a day, or augmentin if your patient has any risk factors or you're worried about, more severe bacteria. If they have a penicillin allergy, doxycycline is a safe choice. If they can take cephalosporins, then a 3rd generation cephalosporin. That's good initial knowledge for you to have. Okay, so here, this is kind of like the same information, just we're going to go into some of those little details a little bit. Again, acute bacterial rhinosinusitis that you have decided requires antibiotics. The drug of choice is amoxicillin or amoxicillin and clavulanate, which is generic for augmentin. Now, this would be if they do not have a penicillin allergy. Again, we can do amoxicillin 500 milligrams TID or 875 BID. The amoxicillin clavulanate, we can give in either the 500 125 TID or 875 125 BID. Again, high dose augmentin, high dose amoxicillin and clavulanate is for our patients who have risk factors. That high dose is like 2,000 milligrams of amoxicillin, and it is extended release, so we give it twice a day. That is a massive dose of amoxicillin. Situations where we would give this high dose augmentin are if the patient's had a recent hospitalization, or if they've had recent antibiotic use. So if they just had, strep throat 2 weeks ago, or they just had an ear infection 3 weeks ago, and they tell you that, a little while ago, 3 weeks ago, they were on amoxicillin for an ear infection. Well, there's a possibility then that this bacteria is resistant. Also, patients are more likely to be getting resistant bacteria from hospitals. So in that case, we go for the amoxicillin with clavulanate, because remember that clavulanate helps to inhibit penicillinases. And then we go for the high dose, that 2,000 milligram twice a day dose. So again, recent hospitalization, recent antibiotic use. If the patient's immunocompromised, also kind of age and comorbidities as well. Like if you have a patient who has a lot of comorbidities and you're really worried about the infection, those are all risk factors. If the patient has a penicillin allergy, again, you can use a third generation cephalosporin like cefepime if they can take cephalosporins. Or you can use doxycycline. Doxycycline's okay either way. Even if they can take cephalosporins, you can give them doxycycline. Either 100 milligrams twice a day or 200 milligrams daily. Again, we treat for 5 to 7 days. If, again, like this doesn't work, if this isn't effective, then you would just use one of the other agents, like one that you didn't use. So you could move on to the high dose augmentin, or you can move on to doxycycline. You can also move on to using a respiratory fluoroquinolone. The respiratory fluoroquinolones, remember, include levofloxacin and moxifloxacin, right? Ciprofloxacin is not a respiratory fluoroquinolone, but the respiratory fluoroquinolones should only be used if these agents are not tolerated. Okay, so your first go-to should not be a respiratory fluoroquinolone. And the reason for that is twofold. One, there are just high rates of resistance developing because we used to throw them at everything. And then the other thing is because of, adverse drug effects like QT prolongation, tendon rupture, etc. Patient factors that we need to consider. So like consider patient's age, consider whether or not the patient's pregnant. For example, doxycycline. Doxycycline and fluoroquinolones cannot be given during pregnancy. So if you have a pregnant patient, you're giving them amoxicillin generally to start, unless they're allergic, and then a cephalosporin, but no doxycycline, no fluoroquinolone to your pregnant patient. Kids, doxycycline, remember, cannot be given to kids under 8 years old. Unless it's, very, very select infections. Doxycycline can be given to kids under 8 if they have anthrax or Rocky Mountain spotted fever, but really that's it. So if you have a kid or a pregnant patient, you're not going to go to that doxycycline. What else? Just comorbid conditions are always going to be something that you look for. And then always, caution your patient regarding the possibility of, antibiotic-associated diarrhea or opportunistic infections like yeast infections that can occur, especially if you go for these higher dose, like higher dose augmentins. Okay, here's another case. A 26-year-old female at 32 weeks gestation presents with a runny nose and severe congestion for the past week. The patient states that she feels pressure in her face and she's getting frequent headaches. She's been taking Tylenol for the headaches with moderate relief. Physical exam reveals facial pain upon palpation, fever of 101 degrees. All of their systems are within normal limits. So meds, prenatal vitamins, no known drug allergies. What's the most appropriate clinical course in this patient? So in this patient, I would choose an antibiotic. She's already waited, 7 days. She's already gone a week and there's no improvement. She's pregnant, so I want to be extra careful with her. And she's got a fever. She has persistent facial pain. Like, these are all signs that this is a relatively severe sinus infection. And again, since it's been a week and we're just worsening, she still has a fever at a week. It's not getting any better. I would start an antibiotic. If she was not pregnant, I think the fever and the persistent facial pain make me say that I might go to an antibiotic, or possibly give it another week and see if it improves. But the pregnancy tells me I'm going to give her an antibiotic. So the appropriate course, no antibiotic necessary. I'm going to give her something. Doxycycline 100 milligrams twice a day for 7 days. That would be okay in a patient who was not pregnant, who was over 8, and who had an allergy to penicillins. But this patient does not check off any of those boxes. So no, I am not going to give this pregnant patient doxycycline. Remember, doxycycline causes problems in the baby. The baby can be born and there can be issues with bones and teeth. So amoxicillin 500 milligrams TID for 7 days. Yes, that is good. Amoxicillin is generally considered safe in pregnant women. 3 times a day is the appropriate dose for the 500 milligram tablets, and 7 days is an appropriate length of therapy. I would also, let her know what symptomatic care is safe in pregnancy. The acetaminophen is safe, which she's been trying. You could also recommend some saline washes. Just again, make sure that the patient knows she needs to clean the pot every time, and she needs to use a fresh bottle of bottled water every time that she does the wash. Okay, our prescription for a patient. So our patient's name, our patient's date of birth, today's date, and then we are writing for amoxicillin 500 milligram tablets. We are going to tell the patient to take 1 tablet by mouth, TID, 3 times a day, times 7 days. That means the patient needs 21, right, dispense tablets. Dispense 21 tablets, 0 refills, and then I'm going to sign it. One thing that's can be helpful on antibiotics as well, guys, is to add in the directions, take take all, or take until done, or take full course, because you don't want the patient to take it for 3 days, start to feel better, and then stop, because that's going to increase the likelihood of resistance developing. Okay, the last thing here is otitis media. And we are talking about otitis media specifically in pediatric patients. So when we have otitis media diagnosed in pediatric patients, the initial therapy is going to be a high dose amoxicillin. So amoxicillin, this is 90 milligrams per kilogram per day. And we do that in 2 divided doses. If the patient has an allergy to penicillins, we can try cephalosporins if they can tolerate cephalosporins. The post-treatment failure, so the patient should notice improvement by about 48 hours. So, and you should tell the parents this, the kid might not be completely better, but you should notice some improvement within the first 48 hours. Sometimes it actually worsens a little, like the first 24 hours. The antibiotic hasn't really had a chance to work yet. So, tell mom first 24 hours, if the, infection progresses, that's okay. But the next day should really see some improvement. So by the end of day 2, we would expect that there's some improvement occurring, and then the little one should keep getting better every day. If there is no improvement by 48 hours, or it continues to worsen through that full 48 hours, then tell the parents they need to call you back so that you can change the antibiotic. Post-treatment failure, so if that amoxicillin is not enough, then we give the augmentin. We give amoxicillin and clavulanate. Again, we dose off of that, the amoxicillin of 90 milligrams per kilogram per day in 2 divided doses. And we treat for 5 to 10 days. Again, improvement should be noted within 48 hours. All right, so here's our last kiddo. Sorry, I'm kind of rushing now. I realize I'm already over an hour, so I'm gonna get through these last couple slides fast. Our patient is a 4-year-old female who weighs 44 pounds. We've got a lot of 44-pound kiddos in this, who you diagnose with bilateral acute otitis media. Pertinent history includes the recent use of amoxicillin. The last dose was approximately 21 days ago. A patient has no known drug allergies. So typically, sorry, we kind of skipped through a lot of details because I'm trying to go fast, but typically we would give the patient amoxicillin, right? That would be our go-to. However, in patients who are at risk for resistant bugs, so for example, if the patient has had a recent antibiotic use, then we're going to go directly for the augmentin. Because again, if the patient was on amoxicillin recently, it's possible that the bacteria have developed, have penicillin or penicillinase producing. So they might be resistant to that amoxicillin. So if we give them the clavulanate as well, that takes care of most of that resistance, or it should. So in this patient, the appropriate treatment choice is instead of giving the amoxicillin, we're going to give the augmentin. We're going to give the amoxicillin and clavulanate. Cefuroxime is a cephalosporin that would be an okay choice for this patient. If the patient, for example, couldn't tolerate penicillins, but they could tolerate cephalosporins, then we could try the cefuroxime. But our patient tolerates amoxicillin just fine. She just had it. She's got no known allergies. So we're not going to go with the cefuroxime. Doxycycline. Doxycycline is an appropriate option for older patients as like a second line agent for older patients, but we do not give doxycycline to kids under 8 years old. And this is a 4-year-old. So we're going to go ahead and give this little one a high dose augmentin for 5 to 10 days. Since this patient is since this patient recently had antibiotics, I'm going to go for that 10 days of therapy just to be safe. So we have to obviously calculate a dose. Writing prescriptions for little ones is a little bit more complicated because of the dosing. Here we see the forms that Augmentin comes in, or amoxicillin clavulanate. We're dosing off of the concentration of amoxicillin. So I've got the amoxicillin doses here. Again, we are going to give our kiddo 90 milligrams per kilogram per day. We want 90 mg per kg per day in 2 doses. So whatever that daily dose is, we divide that by 2. We're not going to give it all at once. Our little one is 44 pounds. Again, 2.2 pounds per kilogram. So that means that she is 20 kilograms. The daily dose, we said 90 milligrams per kilogram times our 20 kilogram little one. So we're going to give 1,800 milligrams per day, right? 1,800 milligrams per day. We do that in 2 doses. So that's 900 milligrams twice a day. Now again, you can't write on this prescription to give 900 milligrams twice a day. It's not like it's a tablet that they can just give one of. The mom needs to measure out this suspension. So if you look up here at the concentrations, you always want to give the kid a small concentration, right? Like a small volume. You don't want to give them like 0.125 mLs because that's going to be hard for the mom to measure. But you don't want to give 30 mLs either because it's really hard to get a little one to drink 30 mLs of medicine. So because we have such a big dose, I'm going to go ahead and go for the 400 milligrams per 5 ml concentration. So let's figure out how many mLs we have to give the little one. Remember, we set up our proportion and we say 400 milligrams per 5 mLs equals 900 milligrams per X mLs. We're trying to figure out how many mLs give us 900 milligrams. And remember, we just cross multiply. So 900 times 5 equals 400 times X. That ends up being 11.25 milliliters. That's the volume we end up with. So 11.25 milliliters twice a day. You can round that to 11. That would be okay. That dose would be close enough that it would be okay. I mean, its bioavailability varies between kids anyway, so you could do 11 milliliters twice a day. So let's write our prescription. Again, all of the patient's information and the date, all of your information should be on there. And then we are writing for Augmentin suspension, 400 milligrams per 5 mLs. The patient is going to do 11 mLs by mouth twice a day times 10 days. So 11 mLs twice a day, that means 22 mLs a day. For 10 days, that means they need 220 milliliters. I'm sure it does not come in a 220 milliliter bottle, so we can say dispense 250 mLs. That will give the mom plenty to do the 10 days, and actually there's a little extra for spillage. However, I'm also going to add at the end of this, discard remainder, because suspensions are only good for a certain amount of time. Augmentin, I believe, is good for, I think it's 14 days. 10 to 14 days, I'm not sure which, but it's only good for, you know, a little while, which means you don't want the mom leaving this in the fridge and, you know, saying, oh, I'll just use it next time they're sick. Also, you don't want them to self-diagnose and self-give antibiotics. So it's important the mom knows, hey, this is not going to be good after the patient's done taking it. So if you have an extra 20, 30 mLs at the end, just toss it, just throw it away. All right, guys, that is it. I'm sorry, we went through otitis media really quick. We didn't really get into the nitty-gritty of when to prescribe and why to prescribe, and all the little details that I would normally cover, but hopefully that was enough to give you an idea of how to kind of initially proceed with therapy. All right, if you guys have any questions, please feel free to shoot me an email. Otherwise, I wish you well on all of your other rotations. Bye.